about immune-mediated respiratory diseases. So what I'm going to discuss today is, first we'll see the defenses of the respiratory system, and then the different pathologies, like what kind of infections immune system can deal with, and the granulomatous inflammation, and finally the more detail will be about allergic bronchial asthma. Before we begin, you'd just like to recall what are the innate and adaptive immune responses of respiratory system. So can you just share your thoughts about what are the possible defense components that you can see in a respiratory system? Sorry? Okay, so the brush-like action of the epithelium, ciliary action. Do you expect any barriers? Physical barriers. So the epithelium comes first, then that has got those ciliary action from the cilias. What else? Mucosa. What it will do? Trap the pathogens. What else they can do? What is air conditioning? Not air condition. Is there any difference between the temperature of the air that you inhale? Yeah, warming effect, moisturizing the air, and then further, which cells, immune cells can you see? Alveolar macrophages. Which else? IgA antibody in the secretion. Okay, let's see here in this diagram. Do you all know what is the difference between airways and air spaces? So from the upper respiratory tract, so trachea, bronchi, bronchioles, and then it finally terminates at the terminal bronchioles. So all this passage all the way from trachea to the terminal bronchioles is normally termed as airways. And then finally the grape-like structure, the alveoli, they are termed as air spaces, where the gas exchange take place. So all these have got epithelium first of all, and as we said that they will have hair-like structure. So these are the non-specific defense mechanism. And then certain reflexes like cough reflex, it's a protective mechanism. So if an irritant enters, the cough is going to push it out. And then finally the lower respiratory tract, the air spaces, they have got macrophages, which are the non-specific defense mechanism. So alveolar macrophages in the alveoli are your non-specific defense mechanism. In between the epithelium, there are cells that are going to produce certain enzymes. So those are the chemical barriers. Lactoferrin will be produced, certain other enzymes will be produced. So they have got antimicrobial effect. The epithelium is the barrier, physical barrier. Mucus production traps the air, traps the pathogen. And then finally the macrophages at the alveoli are the non-specific defense mechanism. Now in this part we are going to see little more details about the cells. So if you look at the first detail of the trachea, you can see there is epithelium, and in the epithelium you can see certain distinct cells. Which are these cells? Goblet cells for production of, and these ones? Intraepithelial dendritic cells. So they are there to capture the pathogens. Then another thing, this is the structure of an alveoli. You can see first there are alveolar macrophages here, and there are also dendritic cells here. So to capture the pathogen, intraepithelial dendritic cells will work in this part, while these alveolar macrophages and the dendritic cell, they will work at the level of the alveoli, and both are going to take the pathogen to the draining lymph node. So their job is to capture the antigen here, their job is to capture the antigen here at the alveolar level. So whether it is the airways or air spaces, the pathogen will be captured and taken to the draining lymph node. This is the draining lymph node where the naive T cell will be primed. Now I would like you to just focus here and see two more cells, the type 2 epithelial cells and type 1 epithelial cells. What these cells are supposed to do? What are their functions? Yes, please.
Try to secrete surfactants.
Yeah.
And type 1 engulf the surfactant to reduce.
Yeah, very good. So these are one function that you can think of. Something related to the immune system, can they do?
And type 1 be phagocytic.
Type 1 are they have phagocytic property as well. So type 1 cells help the immune system in capturing the antigen. Now, what happens if the defenses of the immune system are either dysfunctional or they are not properly regulated? What do you expect? They will not be able to defend your immune system and you will have infections, or if there is exaggerated immune response, there will be damage to the respiratory system. So the possible things that you can encounter are, first is infections. We'll talk about a little bit about the importance, with respect to the components of the immune system. Allergic diseases, that will be our main focus today. Interstitial lung diseases, granuloma formation is also taking place, and vasculitic diseases in the respiratory system. But today I'm going to just focus on allergic and granuloma and vasculitis and interstitial lung diseases for another lecture. So we'll first start with the lung infection. As I said, the alveolar type 2 cells, they are going to capture the pathogen. Alveolar macrophages, they are going to capture the pathogen. But at this point, just remember one thing. So as I said, air spaces starting from the trachea to the terminal bronchioles, it has a more colder environment, so it suits more viruses. So that's why that area is more prone to viral infection. Then from terminal bronchiole onward, in the air spaces, it's more warm environment, and that suits more bacteria. So bacterial infections are more prone in the alveoli, while viral infections are more seen in the upper respiratory tract. Now the infection of the alveoli is termed as what? Pneumonia. Excellent. So the infection caused mainly by the bacteria that will result in pneumonia. Here, whether it's the alveolar type 2 cells or it's the alveolar macrophages, whenever it's taken up, the antigen is taken up, it will first be, so they both participate in inflammation. How? By producing cytokines, chemokines, growth factors. So whether it is the alveolar type 2 cells or it is the macrophages, they both can produce the same things, and that will enhance the inflammation. And finally, the inflammation that results in damage to the tissue. So one thing that I would like you to focus here is that this inflammation that results in damage, this damage will be repaired. And that repair, initially, if there is not persistent presence of the antigen, this repair is normal. So functioning tissue will be produced. But if it prolongs and too much damage occurs, it results in fibrosis and scarring of the tissue. So tissue damage, tissue repair will be either normal or it results in fibrotic changes. Sometimes even there is impaired repair, and that can lead to, there are possible theories about link to cancers. So just remember this. So two main cells that participate in the uptake of the antigen is alveolar macrophages and the type 2 alveolar cells. They both produce cytokines, chemokines, growth factors. All of them will enhance the inflammatory process. That inflammation results in a collateral damage, and that damage has to be repaired if the antigen is removed from the body. But if it persists, that damage will result in scarring, fibrotic changes, permanent changes, and sometimes even the impaired kind of a repair may be linked to cancers. Now the second condition is the granuloma formation. Which diseases have granuloma formation? We have taken that in detail. Tuberculosis. So First, it has to be intracellular pathogen, whether it is tuberculosis or leprosy, they have got granuloma formation. But it's not just that, it can be infective and non-infective. So the causes of granuloma formation are both. The infective causes, you can see leprosy and tuberculosis. The non-infective causes, they include lots of foreign body, such as exposure, constant exposure to talc, hypersensitivity that is caused by the beryllium, and there is vasculitis is also another significant cause of granuloma formation. Vasculitis is the inflammation of all three types of vessels, large vessels, medium vessels, or small vessels, and there are a lot of reasons, immunological reasons for that. And finally, sometimes there are autoimmune diseases that also results in granuloma formation, and one of the disease that is mentioned here is sarcoidosis, that affects the respiratory system as well. So you have two different categories, an infective cause of granuloma formation and a non-infective cause of granuloma formation. Now, what is common to both of them is that two different set of cells. So natural killer cells and gamma delta T cells, they are the ones who initiate the process of granuloma. So one is initiation of granuloma, and then finally what you get in the end as a granuloma formation, we'll see how it takes place. So the natural killer cell, they are capable of producing TNF, tumor necrosis factor, and also interferon gamma. So these are the two main cytokines that are involved in the initiation, and interferon gamma then matures the granuloma. Finally, it's converted into a mature granuloma as a result of interferon gamma. And the other cell is the macrophages and the dendritic cell. So in the first phase, what happens? The antigen will be captured by the dendritic cell, and it will be taken to the draining lymph node, and they will activate the T cells, antigen specific T cells. On the other hand, natural killer cell and mast cells, they can produce tumor necrosis factor, and they will call upon monocytes and neutrophils. Both these cells will come to the tissue where they are releasing these tumor necrosis factor. And finally, we need basically macrophages to interact with these antigen specific T cells. Now, one thing which is very important in this is persistent of the triggering factor. So it's not finished, it constantly stay there. So I'll give you the example of tuberculosis. You see, it's an intracellular pathogen. It stays inside the T cell, and that inside the macrophages, that constantly it tries to kill, but it cannot kill it. That's why the T cells constantly produce interferon gamma, keep telling it, more and more interferon gamma is produced. So macrophages are gradually turned from normal macrophages to giant multinucleated cells. That is the result of this interferon gamma produced by antigen specific T cells. So persistence of the antigen is an important factor, and T cell will trigger this maturation by interferon gamma. And finally, you can see here that in this granuloma, what you have got giant cells. These giant cells have become multinucleated giant cell as a result of constant triggering from the interferon gamma, and they have a collar of T cells. You can see they are surrounded by a full collar of T cells. This whole thing is now termed as mature granuloma. This is the mature granuloma. So whether it is infective or non-infective, like sarcoidosis, this thing will happen. First phase will be initiation, and then finally it's the mature granuloma formation. Now we'll come to the third condition, which is bronchial asthma. The bronchial asthma is a chronic inflammatory disorder. That's one. And three cardinal features are very important when you think of asthma. Number one is airway inflammation. So inflammatory process is very important. Number two is the reversibility of the airway obstruction. So there is one whole group of respiratory diseases which are called as COPD, chronic obstructive pulmonary diseases. They are chronic obstructive pulmonary diseases because they cannot be reversed immediately by the use of medication or by the removal of triggering factor. But asthma, it can be reversed if you remove the triggering factor or you give them the medicine, it will be immediately reversed. So reversal is a very important thing. Then third factor is the hyper-responsiveness. So there are smooth muscles around the airways that can constrict very strongly. So these are the three cardinal features. One is inflammation, number two is the reversal of the narrowing, and number three is the hyper-responsiveness. So they become so sensitive that even a small amount of a triggering factor will result in immediate constriction of smooth muscles. So these three are the cardinal feature of the bronchial asthma. Then if you look at this figure here, this is the normal airway. You can see the lumen is patent. Then these are the smooth muscles that are surrounding this airway. And in this second figure, which is asthmatic airway, you can see the lumen is becoming slightly narrower. There is thickening of the wall of the airway, and finally the smooth muscles around it, they are hyper-responsiveness, so they will constrict very quickly. But then finally there is another figure which shows the asthmatic attack, so when it will constrict, these smooth muscles will constrict and make it even more narrower. So these are the three cardinal features that you should remember regarding the bronchial asthma. And of course, when it is a generalized, constriction or narrowing, so before we go further, when it says generalized narrowing of the airway, what does it mean? Sorry? The word, when I say generalized narrowing of the airways. Obstruction. There will be obstruction, but what does generalized mean? Bronchi, bronchioles, terminal bronchioles, and everything all the way. Because there are many times when I interact with the students, they think that asthma is just the narrowing of the basically upper part of the like trachea and just bronchi. No, it's generalized, it's all the way. That's why if you focus on the clinical features, patients have got wheezing and chest tightness, because airways go all the way down into the lungs. So when they are narrowed, that's why they have got these chest tightness feeling. They tend to have a specific posture so that they can breathe in, and you can see their muscles around the neck and the intercostal muscles, they are doing extra effort. All these features are because there is a generalized, all the way from trachea down to the alveoli, there will be narrowing. So generalized narrowing means all the way. It's not just one part which is constricted or narrowed. Now, what are the triggering factors for this bronchial asthma? It can be, like allergic causes or antigenic and non-antigenic causes, and they can also have relationship with different type of seasons. So a seasonal history can be there, that in autumn or spring or winter they can have an attack, and that is for different reasons. So one is presence of the pollens in the environment, or in the cold they tend to have more influenza attacks. So one triggering factor can be season, pollens, another can be cold weather or viral infections. And the perennial season, perennial pattern, what does that mean? Anyone is aware of perennial attacks? Or so long term, which has nothing to do with the seasons, it's all the way. They will tell you that for the last 3 years or 4 years I constantly have attacks. It's irrespective of what's the season. Then there are non-antigenic factors. Here you can see smoking, fumes, car fumes, and or exhaust, and exercise. So these are the non-antigenic triggering factors. But before we go further, At this point, you should know that asthma is classified into allergic asthma and non-allergic asthma. Allergic asthma is around 60%. So when you come across the patients, 60% of the patients will be allergic asthma. Remaining 40% are non-allergic. And in that non-allergic, there is again two groups. One is idiopathic, where you don't know the cause. And 10% are where you know the cause, but you don't know the mechanism. So in the allergic asthma, there is a very fixed pattern of, so the causes are known, the Immuno Pathogenesis is quite clear that it's a Th2 IgE mast cell mediated type 1 immune response. While in non-allergic asthma, the Immuno Pathogenesis is not very clear. In small part, 10%, you know that it is caused by these things, but you don't know the exact mechanism. And the remaining 30%, which are termed as idiopathic, you don't know the causes and you don't even know exactly what is the immunopathogenesis. So you can see this first group is of allergic asthma, the second group is idiopathic, and then this third one is the category of others, where you know some of the causes: aspergillus, exposure to aspergillus, or carcinoid tumors. Some situations where they resemble cancers, such kind of tumors can result in asthma as well. One very important thing is that age group. If you see the allergic asthma, it's commonly seen in childhood. If you remember in your type 1 hypersensitivity reaction, I told you that they have allergy march. Patients tend to have first other things like atopic dermatitis, they will have food allergies, and then rhinitis, and finally later on they develop asthma. So in the childhood everything starts, but in this idiopathic group you can see it's mostly seen in more than 40 years of age. So age difference is one important factor between them. Then if you see, they have got seasonal pattern, they have perennial pattern, occupational, while this one has no clear-cut demarcation. It has got a link with perennial or with season, no, because we don't know exactly the cause. And most fatalities or deaths are commonly seen with this one, the common one, which is the allergic bronchial asthma. Bronchial asthma can also be phasic, so it's not like it's just one type of asthma, that there is an attack, bronchiolar constriction, mucus production, hyperresponsiveness, and that's it. And when you give them the drug, it's just reversed. No, it's phasic because it's a chronic condition. With age, it changes. So in the first initial phase of life, it is going to be acute inflammation. Later on, when it persists or more and more attacks occur, it's going to change into chronic inflammation. And gradually, finally, it can change into airway remodeling, where the structure is changed. There are going to be, as I told you, that there will be repair, damage and repair, and that repair is going to change into remodeling. So constant changes will occur into the airways. And so the second one will have exacerbations, more attacks, more exacerbation, and then try to treat them with the medicine. But the last phase, where there is very much damage, it's constantly having fibrotic changes, airway is changed, then that will convert into obstruction. So just consider it as a life-changing process. So initially it's different. In the middle part of the life, if you avoid allergens, so people who have allergies to cats, dogs, or pollens, if they change their environment, they move on to another place, things will be different. But if there is persistent damage, whether it is occupational, for example, the person keep on doing the same job and have attacks, it will result ultimately into the damage, and there will be remodeling of the airways. Now, the immunopathogenesis, we have already discussed it in type 1 hypersensitivity, but I'll just add to it certain more things. epithelium that we talked about as a physical barrier in the airways or air spaces, they have got very tight junctions. They will not allow the allergens to enter into the airways. But there are strong associations, genetic association with different factors. Like here you can read, there is something called as gene SMAD3 or gene IL-33. So presence of these genes in certain individuals in these epithelial cells, these people are more prone to develop bronchial asthma. So if you think about the major component, that is allergic bronchial asthma, they have got genetic association with these two genes in particular, and they are more prone to develop bronchial asthma. Then different factors which are not antigenic, like exposure to smoke, that can cause damage to these epithelial cells. So presence of these genes or exposure to irritants, that can then result in changes in these epithelial cells, and they will allow the entry of the allergens into the airways.
Have these genes?
Not all, everyone does not have these genes. Or sometimes the presence of these genes. So for example, normally IL-33 is in other epithelial cells. For example, the GIT epithelium. They are not necessarily supposed to be in the respiratory epithelium. So presence and where. So in this part, if they are present, SMAD3 and IL-33, they will make people more prone to bronchial asthma.
Is it abnormal to be in the airways?
Yeah, if their presence is in the air space epithelium, yes. So once the allergen has entered the air spaces, they are going to trigger the epithelial cells to start expressing immune receptors. If you remember, all macrophages and dendritic cell have got PRR, pattern recognition receptors. When allergen, activate or cross these epithelial cells, they start to express PRR. And once they start producing PRR, they are going to call other immune cells like dendritic cells and macrophages to come closer here. And in the first figure I told you that there are already, for example, type 2 cells or alveolar macrophages and the intraepithelial dendritic cell. They all are going to capture the antigen, and then they are going to present the antigen in the draining lymph node to which cells? T cells. The priming is going to take place inside here. So these dendritic cells are going to present it to the T cell. Which type of T cells? Th2. Allergy and asthma, that is, very strongly associated with Th2. At this point, so there are different theories regarding why people, so a lot of students ask why some people are prone to have allergies or asthma, some people don't have. One theory is regarding the hygiene hypothesis. Maybe I've talked about it before, that if we check any one of us, I take blood sample from any one of you and look at the count of Th1 and Th2 cell at any time, there will be domination of one type only. That depends on your previous life. So which kind of infections you had in your previous life, that will result in one Th1 or Th2 be dominating. So if it is Th1, there are very less chances that you have allergy or bronchial asthma. But if your Th2 count is more, which is seen more in people who are very clean or who tend to have very less infections. So if they are too clean, and that is why it's linked with the Western countries. The Western countries tend to have more asthma and allergies. Why? Because they think it's more cleaner environment, less Th2 dominates. So when the dendritic cell exposed, they are more likely to express these antigens to Th2, and sensitization will take place. So if this Th2 is polarized, which cytokines it's going to produce? Very good. IL-4, IL-5, IL-13. So when these are produced, what they are going to do, for example, IL-13 is going to cause B cell switching to IgE, while IL-4 and IL-5 eosinophils. So you have got now in the body in the these lungs you have got eosinophils, and B cells will produce IgE. These IgE is going to coat the mast cells, and then this first phase is termed as sensitization. On the next exposure, when they will already be present on the surface of the mast cells, they will result in degranulation, release of histamine, prostaglandin, and for the late phase, certain cytokines as well. Then one theory I have explained is about the hygiene hypothesis. Another theory is about the association of Th2 and Th17 cells. So now more and more allergic and asthma patients, they tend to have the Th17 involvement as well. So when Th17s are involved, which cytokines they produce? IL-17. And which cells they call upon? Neutrophils. Very good. Now here another thing that I would like to tell you is that if you will do a BAL, what is BAL? Broncho-alveolar lavage. Nobody remembers? So you insert a bronchoscope in the patient, it washes the alveoli, and then bring out viable cells, live cells. So why I am telling you this, because if the patients have got more number of neutrophils in their BAL, they are more severe cases of asthma. So if their BAL has got more neutrophils, these are severe cases. And if their BAL has got more eosinophils, then these are mild cases of allergic asthma. Okay, so this is another theory, that with the Th2 cells you will find more Th17 cells. Those Th17s will call upon neutrophils, and if on the bronchoalveolar lavage the ratio between neutrophil and eosinophil, neutrophils are more, that is severe bronchial asthma, and if the ratio is more in favor of eosinophils, then that is more milder form of the allergic asthma. Any questions so far regarding this part? Everyone understands it? Okay. So now as a result of histamine, what will happen? There will be vasodilation, and that vasodilation actually causes the release of the blood and swelling of the wall. Vascular leakage, more cells will come, and bronchoconstriction, the smooth muscle around the airways, they will constrict. So what you will see, of course, the asthma symptoms. Now, I already talked about it, the three cardinal features of asthma. What we said, one is inflammation. Number two, reversibility. And number three was hyper-responsiveness. So that reversibility is this. You can see here, on one side is untreated lung airway with asthma, and on the right side is lung airway after asthma treatment. You can see a very clear difference, that here the airway is totally blocked or obstructed with the mucus, with the narrowing of the lumen, and with the thick wall. After the treatment, what happens? The lumen is back, it's now patent, the wall has slightly reduced in thickness, and the smooth muscle constriction has been reversed. So this reversal is a key feature of bronchial asthma, as long as the remodeling has not taken place. When remodeling takes place, then this cannot occur. Now we'll see here all the clinical features, and you can link it to the location, to hyperresponsiveness, mucus production or bronchiolar constriction, and generalized affecting the airways. You can see, for example, shortness of breath. Why does they have shortness of breath? Okay, some sort of thickening of the alveolar basement membrane. Sure? Nothing will happen there? Will it affect the gas exchange process? More concentration of carbon dioxide. What does more carbon dioxide concentration triggers? Hyperventilation. Very good. So there is rapid breathing, and because of the oxygen concentration is low, the patient is short of breath, then pale and sweaty. Why? Because there is exertional breathing now. He is specially trying to breathe. That's why you will see special effects, intercostal muscle involvement, neck, you will see these muscles are involved, exertional breathing, then blue lips and fingernails. Why is that? Hypoxia. Tightness in the neck muscles because he's trying to expand the chest to breathe in. Choking sensation because of a lot of narrowing and mucus plugging, and difficulty in talking. When you do a strong sprint and run around, after that, is it easy for you to talk? So it's similar kind of feeling with this patient. Anxious. Why is the patient anxious? He cannot breathe. He is in difficulty and pain. And severe wheezing, the whistling sound that is produced, of course, very narrow airway, so the air is rushing in and out, that is causing the production of wheezes. And cough, because he has to cough out mucus so that the airway is little bit cleared up. And these all features are the result of either early phase response, which is the histamine and prostaglandin release, or the late phase response because of the productions of the cytokine and inflammatory process. Now, as I said, first phase is initiation, then we go on if there are repeated attacks, again and again attacks, exposure to the allergen, it will result in chronic inflammation. And the late phase, so the cytokines that are produced, Innate, TNF, they are going to increase the inflammatory process and damage. Of course, it is going to affect the same things, the vascular permeability, bronchoconstriction, more inflammatory cells, more damage to the air spaces and airways. Now, if you look at the difference between the normal and a bronchial asthma, wall, here you can see epithelium, the lamina propria. How many cells you see? Inflammatory cells. Very few. But here if you look at this, the whole thickness is full of the neutrophils, eosinophils, mast cells and lymphocytes, T cells. So they have completely filled the lamina propria, and they are increasing the inflammatory response. And of course the goblet cells are more and more triggered to produce the mucus. And finally the airway remodeling, so it is continued, this inflammation has continued for so long that it has now started changing the structure. How it can change? You can see the first on top is the inflammation and thickening of the basement membrane. So yes, if it prolongs for years and years and too much inflammation, now the basement membrane has become thick, so the gas exchange will be quite a lot affected by this. Mucus hypersecretion, lot of glands and lot of mucus production. Subepithelial fibrosis, so when the cells are there, more repair will take place, and fibrous tissue is going to replace the normal functioning tissue. And with the time, the smooth muscles contract and relax, they are going to become hypertrophied. Their sizes are going to be increased. And then irreversible narrowing of the lumen. At this point of time, the narrowing cannot be reversed. And finally, there is decline in the lung function. So, in a summary, just asthma is characterized by reversible bronchoconstriction caused by airway hyperresponsiveness to a variety of stimuli. So there is narrowing and it can be reversed. Atopic asthma is caused by Th2 and IgE-mediated immunological reaction to environmental allergens. That's the main 60% of the allergic bronchial asthma. The Th2 cytokines IL-4, IL-5 and IL-13 are important mediators. Eosinophils are key inflammatory cells found in all subtypes of asthma. Eosinophil products such as major basic protein are responsible for airway damage as well. And airway remodeling will take place finally as if it continued for very long, and it adds to the element of obstructive disease. So if you have any questions, yes.
Doctor, you said eosinophils are the key inflammatory, but earlier you said that mast cells release their mediators that cause.
Yeah, sure. See, when we talk about the type 1 hypersensitivity, it is initiated initially by mast cells, and that is the main initiation factor and the key. But in bronchial asthma, what they do, they are going to produce